We are live.
Okay. So good evening, postgraduates, and welcome to this 62nd episode of All India Postgraduate Teaching Program, an initiative from ARC AOS. This PG program, we call it a program with difference because here we try to have case presentation, journal clubs, OSCEs, and rarely a didactics, especially on topics which are not comprehensively available for you in a textbook. So in this 62nd episode, we have a didactic lecture on causes and management of glaucoma associated with ocular trauma, which has been a long question in one of the MS finals. And it would be presented by none other than Dr. Ronnie George, who is a well-known faculty in glaucoma, and also is a glaucoma consultant at Shankanetralaya, Chennai, and also a director over there. My special thanks goes to the other expert panel, Dr. Prashant Bhushan, who is Professor and Head Department of Ophthalmology at Institute of Medical Sciences, BHU, Varanasi. My dear friend, Dr. Samir Narang, who is a Director, Narang Eye Care and Laser Center, Ahmedabad. And Dr. Vinita Ramnani, who is a glaucoma consultant at Bansal Hospital, Bhopal. So postgraduates, all these four people are big luminaries in the field of glaucoma. And you are fortunate that today's talk would be taken by none other than Dr. Ronnie George. Without much ado, can I request Dr. Ronnie to share his screen?
Thank you, Dr. Prashant.
Thank you
for the kind invitation and asking me to speak here.
Yeah, we can see you.
Yeah. So today what I will try and do is I will try and speak to you about some of the reasons, the causes for glaucoma. I'll be focusing mostly on blunt trauma because that's one of the more common causes for glaucoma that you see. But I'll cover the rest in brief. So when we look at penetrating trauma, blunt trauma, chemical burns, radiation therapy, or electrical injuries, all of these can land up with glaucoma. So penetrating glaucoma typically commoner in young men, just like most other trauma. And glaucoma can be associated with or without retained foreign bodies. You always have to look for signs of past trauma or penetrating foreign bodies whenever anybody comes to you with unilateral glaucoma. Because unilateral primary open-angle glaucoma is a disease of exclusion. So look for any of these, which can be a facial scar, a very deep anterior chamber on that eye, anterior chamber asymmetry, pupillary sphincter tears, a osseous ring or a ring of pigment on the iris, iridodonis or phacodonosis, a previous small subtle scar, any iris holes, and any lens capsule rupture or localized damage, localized cataract. All of these may give you the indication that this person has previously had injury, and that's the reason for the glaucoma. So the pathophysiology in most of these eyes, typically you will see it post-repair, and usually that's a late presentation, unless the entire lens matter and everything has been disrupted in the anterior chamber, or the globe rupture is not because of a sharp injury, but because of a blunt trauma. So there's a significant blunt trauma component, which has been so severe that it has resulted in rupture of the globe wall. In that case, you have a combination of both the blunt trauma risk as well as the penetrating trauma risk. And the reasons here are usually secondary to inflammation because of synechiae or pupillary block or epithelial downgrowth following trauma, or a hemorrhage, which can present a little late. This is common for both types, or lens damage, which can land up with phacolytic or lens particle or phacomorphic glaucoma, or rarely when you have siderosis or chalcosis because of the material of the foreign body. So this is, these are mostly rare reasons for glaucoma, and we will not go to that too much, but you should know about it. With chemical injuries, you can actually get glaucoma when there are severe alkali or acid burns. And the reason for this is because of scleral shrinkage. So when there is scleral shrinkage, there is increase in uveal blood flow, and this causes increased epithelial venous pressure, which causes resistance to flow. And there's a rapid initial rise. But this is usually settles down with time, and the intermediate rise that you see is because of inflammation. And the late onset that you see is because this inflammation damages the trabecular meshwork, causes synechiae, and you get other intraocular scarring. So generally, you treat these just like you treat any other inflammation with aquasuppressant cycloplegics. Filtration surgery is an option, but don't forget the conjunctiva in these eyes or the surface in these eyes can be very, very bad, and that can be a challenge. Radiation injury, again, secondary to radiation therapy for intraocular, periocular, intraocular neoplasms. These usually do badly because they're usually present with neovascular glaucoma or hemolytic glaucoma or raised episteal venous pressure because of orbital scarring. And these typically have poor prognosis, and they're difficult to manage because the tissues are very, very friable. And lastly, electrical injury, which is accidental injury or because post-cardioversion or electroshock. And here, this is mostly because of massive amounts of pigment dispersion. Even though venous dilatation and contracture of extraocular muscles has been described, what you see typically in most of these patients is massive pigment dispersion, which clogs the meshwork and causes secondary glaucoma. But I'm going to focus most of the talk on blunt trauma because a lot of these parameters are covered there too. So this is possibly the commonest cause of ocular trauma, 40% of cases, and typically young men. In fact, they outweigh women almost 4:1. And most of them are young, less than 30 years of age. Sporting and domestic accidents in the West have accounted for 2/3 of cases. And all of us who have been in any outpatient will know kids who come in with, any type of trauma, and they'll find anything to play with, whether it's a pencil or a stick or a cricket bat and ball. And the front part of the eye is most commonly damaged in all these. And when you look at the incidence of people of glaucoma in people who have had a closed globe injury, and this is a paper from Dr. Amanjeet published about 15 years back. And there you find that the incidence is bimodal. In the sense you get one peak which is early and one peak which is late. So soon, within the first 6 months of follow-up, 3 to 4% of people actually turned up with glaucoma in their case series. 10 years after trauma, you had about 10% of people with glaucoma. So the important thing in these eyes is anybody, even with minor angle damage, needs to have lifelong follow-up because they can convert at any time. And why does this happen? And this typically happens if you look at this picture here, you have a blunt object striking the eye, that's compressing the globe, and then that's rebounding back. And this results in anterior posterior globe compression. And this results in equatorial or scleral stretch, which is what you're seeing in the middle picture. And that results in posterior displacement of the lens iris diaphragm, which causes a sudden rise in intraocular pressure and splitting or tearing of tissues. So how does this lead to glaucoma? And I'm going to show you a few graphics after this. If you look at this as a graphic for the trabecular meshwork, this is what the meshwork looks like. It's basically a cross-section of a filter. And this is where what happens if you consider that the brown portion is the meshwork and the white and the blue portion is the Schlemm's canal, the meshwork drains into the Schlemm's canal. And I'm going to just use this graphic to try and explain to you what happens. So typically when you have blunt trauma, what happens for trab meshwork can be as simple as a tear across it. If it has torn halfway through the insertion, this is what will happen. And then both these areas will scar. And that is one of the causes of glaucoma. The second thing that can happen is you can get blood. Because when you get a tear anywhere in the eye, you end up with blood. And this blood clogs the intertrabecular spaces, and that causes obstruction, and that can cause high pressures. Or you can land up with pigment. So pigment can be liberated because the iris is injured, you have damage, you have the ciliary body is stretched, and you have pigment floating around, and this can also cause the entire meshwork to get damaged. Typically, it's a combination of these two which causes most of the high pressures that you see early on. But there are other trabecular meshwork changes that you should not forget about, and that is inflammation of the trabecular meshwork beams. Because don't forget that trauma has happened exactly where the meshwork is connecting to the globe. And that's also stretched, and that leads to inflammation. And that combined with the blood and pigment and sometimes inflammatory cells or lens matter causes the entire trabecular meshwork to fail, at least temporarily. And this is what leads to glaucoma. And keep in mind, remember what all is that: inflammation, blood, pigment, and inflammatory cells. And you have to think about some way of dealing with each of these. And that's essentially how you are going to manage an inflammatory glaucoma. When you have angle recession, which we will talk about a little later, this happens basically because the entire angle is pushed posteriorly. So the insertion of the angle is displaced posteriorly. And what happens when you get angle recession? For example, in this eye over here, the red marks 180 degrees of angle recession. Here, the angle has moved from its normal anatomical location, and therefore it is not draining into the Schlemm's canal. The connections with the aqueous veins are gone, and that part of the angle is essentially non-functional. So most of us have enough extra angle. So even 10, 15, 20% damage may not lead to glaucoma in everybody, but over time, as the meshwork gets compromised, you tend to get more and more glaucoma. And that is why trauma has a bimodal peak. So when you look at the mechanisms of glaucoma, you can divide it into early and late. So typically when you look at early glaucoma and you look at open angles, the commonest causes are trabecular meshwork obstruction and direct trabecular meshwork inflammation. I just showed it to you, and I think that should explain it to you. Closed angle you can get because of ciliary body swelling. And why does ciliary body swell? Again, the same thing. When you look at the entire tissues being stretched, the ciliary body is being pushed back and bounded back. And the inflammation itself will cause it to swell. And this can cause the ciliary body to rotate anteriorly and cause secondary angle closure. Some types of hyphema can cause a closed angle, and I will talk about that a little later. Of course, once you have injury to the angle, lens damage is very common. So lens subluxation and traumatic cataract both can land up with a secondary angle closure because the lens has moved forward. When you look at late mechanisms with open angle glaucoma, most of it is angle recession. Rarely you can get it because of altered blood products like a hemolytic glaucoma or a hemosiderotic glaucoma if there has been a lot of iron leakage from the cells, or you can get a phacolytic glaucoma if there is a traumatic cataract which has been ignored or started leaking early. Closed angles late are typically because of peripheral anterior synecdoche, which can land up with a pupillary block, or with neovascular glaucoma, or secondary to vessel damage. And so these are basically the mechanisms of blunt trauma that you need to be aware of. And if you keep this in mind, you can actually decide what you need to do for each of these conditions, because the treatment for each of these conditions is fairly straightforward. When you look at glaucoma, one of the important things is that you need to do a workup. In the sense, you need to take a detailed history of the time of injury and vision loss at that time. You need to take a medical history of bleeding disorders or sickle cell disease, and also whatever medications a person is on. You need to rule out a rupture and ocular foreign body, and you need to look at the amount of layering if there is a trauma. The periocular exam is important. You may need to do other blood tests, which as required. You may need to screen for sickle cell. You may need to do a CT scan if you suspect anything. But what's more important than this workup, because this you can get from any textbook, is there are a few things that you would be expected to say in an exam. One is a complete exam is critical. A history of loss of consciousness is very important, because you don't want to take a patient into the operation theater and find out that he's had an intracranial bleed. You need to look at the mechanism of trauma, and you need to assess this in detail, because you need to rule out the possibility of an intraocular foreign body. You need to make sure what the vision is like, and you need to also ensure that you know why the vision is what it is. Is there a reason that the patient has 636 vision? You need to rule out orbital trauma, because that can have other implications. And very, very important here, you need to assess a relative affluent pupillary differential. Because don't forget, glaucoma can coexist with any of these. It can coexist with an IOFB, it can coexist with traumatic optic neuropathy, which needs to be treated urgently. It can coexist with an orbital blowout fracture, which also needs to be managed. So these are the minimum things that you would actually need to do. And it would be very, very important for you to speak about this in your exam, and as well as when you're writing an answer. So I'll just discuss a few clinical findings here, because these can come up in an OSCE and you may be asked to talk about this. So this is basically somebody with, if you look at this is an eye with a traumatic cataract with sphincter ruptures. You can see microsphincter ruptures all around and traumatic mydriasis. Very common presentation that you're likely to see when a patient comes to you. You may have other iris trauma. The one picture on top is again just a traumatic mydriasis with early anterior subcapsular cataract. The one below is a little bit more spectacular. You're seeing multiple iris tears. You're seeing blood in the anterior chamber, and you're seeing some amount of fibrin. You can sometimes even land up with aniridia. You can land up with angle recession, and in angle recession, you need to assess the angle closely and always compare the same quadrant in the other eye. So what you will see is this widening of the ciliary body band, which you can see in both pictures. And you may see an irregular insertion like you're seeing in the right side, and that's more localized angle recession as compared to the other eye. Keep in mind that when somebody comes to you with acute trauma, you don't have to place a gonioscope on the eye, because you might actually dislodge a clot and lead to a secondary bleed. Knowing whether the patient if the patient has high intraocular pressures, knowing whether he has angle recession or not at that stage does not make a difference to the management. This is more important further down the road while treating the disease. Sometimes all that you will see in a patient is this little black ball in the angle. This black ball in the angle is basically altered heme. You may not see too much of a recession or just a very subtle recession, but the presence of this black ball in the angle is the typical feature of past trauma and will give you the hint as to why this patient has elevated IOPs. You may sometimes see this, which is lens matter, hyphema, inflammation, mixed with vitreous. And this is somebody with a fairly severe type of glaucoma. These are difficult to manage because you have trauma both in the front part and the back part of the eye. And usually you will need to reach out to your retina colleagues like Prashant for some help in dealing with this, because this is one of the situations where you might do a combined approach to take care of the problem. If the injury has been severe, you can also land up with an iridodialysis. Keep in mind that while an iridodialysis on its own does not lead to glaucoma, and iridodialysis is almost invariably associated with angle recession and angle damage, at least in the region of the dialysis. So, and iridodialysis is also an indicator that this patient is at higher risk of developing glaucoma in the future. If you look carefully, sometimes you can also see a cyclodialysis. And what you're seeing there, the little white cleft, is basically where the ciliary body itself has separated from the eye. These eyes are typically not associated with glaucoma, they're associated with hypotony. The risk in these eyes is sometimes down the line, the cleft closes on its own. And when it closes on its own, you will end up with a very, very severe acute glaucoma. Because an eye like this, which has a cleft, is very hypotenuse, the meshwork has been completely dysfunctional. And after a few months or few years when it closes, the pressure spike that you get can be crippling. And this is also a problem. If you ever repair these, you might land up with a large spike. Sometimes you'll see a patient like this, who's basically came to us 6 years post-trauma. He had been had a corneal tear repaired somewhere else, and he came with fairly significant glaucoma. And when you put a gonioscope in his eye, you see an intraocular foreign body sitting in the angle. It was a glass foreign body, so it didn't incite too much inflammation, but there are localized synechiae around there. And this patient required a IOFB removal along with a trabeculectomy. So gonioscopy is important not only early in disease, but late in disease, both in blunt trauma and in penetrating trauma, because you may have additional features there that you need to look for. I spend a little bit of time on hyphema because this is something which is a commonly seen, and this is something that everybody should know how to deal with. And this is again because a concussive trauma causes the pressure to rise, causes the tissues to stretch, and the fragile vessels of the angle and the iris bleed, causing a hyphema. So whenever you look at a hyphema, it is basically a collection of blood cells in the anterior chamber. It can be a microhyphema where you may not actually see anything very much. You may just see a vague reddish glow, and you will only see that when you take an aspirate. A macroscopic hyphema is when you see a visible layer of red blood cells in the anterior chamber, and sometimes, just like in the previous picture, you can see it even without a slit lamp. You typically grade it as a grade 1 if there is blood occupying less than 1/3 of the anterior chamber, grade 2 if it is between 1/3 and half, grade 3 if it is half to total, and grade 4 if it is complete filling or an 8-ball hyphema. And this is important because the management of these is dependent a little bit on how you grade them. An 8-ball hyphema is basically also called a black ball hyphema. And the reason it's called an 8-ball is because in billiards or snooker, I don't know which of the two, the 8th ball is black in color. And this basically occurs because you get a dumbbell-shaped hyphema which fills the anterior chamber and also fills the retropupillary area. So you'll end up with a sort of a dumbbell-shaped hyphema on both sides, and that results in total angle closure and very, very high pressures. And the black ball is because of the reduced oxygenation of the intracameral blood. So what happens to most of the hyphemas? Most of them will resolve in 5 to 6 days. Typically, the mean duration of IOP is also just about 6 days. A secondary hemorrhage occurs in about 1/4 of patients. And a secondary hyphema is more likely the higher the primary hyphema. So if you have a grade 3 or grade 4, you're more likely to get a rebleed. And how do you manage these? The management is analgesics, keep the patient pain-free, keep the head end elevated, and restrict activity so you get layering of the hyphema. Give topical steroids and cycloplegics. Topical steroids are basically to reduce the inflammation, and cycloplegics are, some people consider it controversial, but cycloplegics help because they minimize pupillary movement, iris movement, and therefore reduce the risk of a clot dislodgement. The reason it is considered controversial is because some people feel that some of the hyphema drains through the surface of the iris, and therefore by dilating it, you're reducing the surface area. But I think today most of us would agree that cycloplegics are an essential part of hyphema management. You also need to give anti-glaucoma medication, which medications we'll discuss briefly. And basically, you could give beta blocker or an alpha agonist or a carbonic anhydrase inhibitor. Avoid things which can worsen the inflammation, and that's basically the miotics and prostaglandins. It's not an absolute contraindication for prostaglandins, but miotics definitely you avoid because they can increase inflammation significantly and might also sometimes lead to, if you have a subluxated lens, give you more trouble with the lens moving anteriorly. So how do you follow them up? You examine the patient daily at the slit lamp, and keep in mind, very often when they first present to you, the IOPs may be low because there's a certain amount of ciliary body shock which causes low IOP, and the IOP spike may be seen at day 2 or day 3. Record vision, record IOP, record corneal clarity is very important. Record the height of the hyphema. Look for signs of rebleeding, and consider doing gonioscopy after 2 to 6 weeks, well after the hyphema has cleared. And do a fundus examination with scleral indentation after 4 weeks, because in addition to the angle, you can get significant trauma to the peripheral retina. So typically, what are the indications? And there are multiple different algorithms followed, but a total or near total hyphema with IOP of more than 25 millimeters of mercury for more than 5 days is an indication for surgical clearance. Early corneal blood staining, irrespective of the type of hyphema, is an indication for surgical drainage. And in order to avoid optic nerve trauma, if any type of hyphema with an IOP of more than 50 milligrams for 5 days, 50 millimeters of mercury for 5 days, more than 35 millimeters of mercury for 7 days, or 24 millimeters of mercury of more than 24 hours in patients with sickle cell trait or disease are considered to be indications for evacuation of the hyphema. And hyphemas which are filling more than 50% of the eye for more than 8 to 9 days are also considered for drainage, because there is a high risk of peripheral anterior synechiae developing in these eyes. So surgical techniques, essentially you do a paracentesis or an anterior chamber washout. You can do mechanical expression of the clot. Very often the whole clot will come out on its own. You may also need to consider, we don't consider cryo extraction, but removing with vitrectomy instruments is actually very helpful, because you don't dislodge the clot. You're not tearing the clot. You're just cutting it off wherever it is in situ. And you are less likely to cause a rebleed in that situation. Sometimes if the IOPs are very high and have been high for a few weeks, you may need to combine it with a trabeculectomy. The concern in this situation is basically because you're very likely to have a rebleed. Most of these trabeculectomies don't succeed very long, but you very often don't need them to succeed very long, because you just need to tide over the acute phase. And what happens to these patients? Most of them recover vision of 20/50 or better in 80%. And if you have had a rebleed, then you're less likely to recover full visual acuity. Keep in mind this corneal blood staining, which initially starts as stippling of the cornea, is one of the indications for immediate drainage. It is usually associated with raised IOP. And while it is, it tends to clear with time, that time can be pretty long. You also keep in mind that you need to know, at least when you're writing an answer, that you can use systemic AC agents in the prevention of recurrent hemorrhage. And this works by competitively inhibiting plasmin and delaying clot lysis. So the options that you have are basically tranexamic acid or epsilon amino caproic acid. And these are the dosages. Most of us don't give it routinely except in high-risk cases. And keep in mind that there are contraindications like clotting disorders and hepatic renal disease and pregnancy, and maybe we can discuss this a little bit more in the discussion. Which patients get recurrent hemorrhages, and that is up to 35% of traumatic hyphema, typically 2 to 5 days following blunt trauma. The time of highest risk is within the first 1 week. If you've tided over the first 1 week, you are unlikely to rebleed. And these eyes typically have a poorer prognosis. The recurrent hyphema is usually larger than the initial hyphema, and they are also at greater risk of long-term secondary glaucoma and corneal blood staining. I've already discussed the surgical management here, and keep in mind that the corneal blood staining I'm just going to speak of for a bit is because of endothelial cell decompensation associated with passage of hemoglobin into the corneal stroma, which is why you see stippling, and stippling is best appreciated with a high magnification at the slit lamp in the corneal stroma. And it can be sometimes difficult to make out in a patient who's also got loose blood floating around the AC. And this is something which you need to look at regularly to be able to monitor, because the cornea can become completely hazy and can take a very long time to clear. This is something else that you might see, and this is basically not a sign of early trauma. This is something which usually occurs 80 to 100 days after the trauma, and this is because of altered blood. And what you're seeing here are ghost cells or khaki-colored cells. And if you look at the symptoms, you'll have pain, you may have normal high IOP, you may have corneal edema, you have khaki-colored cells, and you have this classic candy stripe sign which you're seeing over here. You can see streaks of khaki with the blood. And this can keep changing, this pattern can keep changing depending on how it is layered. Typically on gonioscopy, the angle is open, but this is, of course, once everything is cleared only, you'll be able to do gonioscopy in these patients. And this is because following intraocular hemorrhage, the RBCs degenerate in the vitreous, and then they migrate forward to the anterior chamber through the disrupted anterior hyaloid phase and obstruct the trabecular meshwork. So keep in mind, if you're seeing this sort of ghost cells, that means there is zonular compromise. And if you're planning to go into the eye, expect that the lens may not be completely stable. Angle recession glaucoma, which is the commonest, is basically a misnomer because it's not recession of the angle, it's a tear between the longitudinal and ciliary muscle of the ciliary body. And as I showed you on gonioscopy, there's irregular widening of the ciliary body band. You see it in almost all cases of traumatic hyphema, and the risk is higher the greater the degree of recession. 4% in eyes with recession of less than 180 degrees and 10% in eyes with recession of more than 180 degrees. And glaucoma can occur weeks to years after initial trauma. The reason why the risk increases over time is also partly because an endothelial layer, just like the desmids, can grow over the remaining anterior chamber angle and cause this. And this is a patient who had trauma 10 years prior to this. And when you look at his disc, you can just see an inferior nerve fiber layer defect right there. You can see the little black balls in the angle with localized recession. And you can see a small paracentral visual field defect. And this is a very common presentation in traumatic glaucoma. They're just present with early findings like that. This man, of course, had pressures of 34, so it was unlikely to be missed, but sometimes it can be subtle unless you look for it actively. So how do you manage them? Except for the contraindication of pilocarpine, most of the other management is similar. You can give aquasuppressants, you can give prostaglandin analogs, you can give cycloplegics are not required in the chronic phase. In acute phase, it may be required. SLT and ALT have less success in these eyes than other eyes because the meshwork is already compromised and whatever is remaining may not recover very well. Filtration surgery is an option. Keep in mind again that subluxation of the lens is something that you need to watch out. You can sometimes have vitreous present. You can have the lens sublux and cause a shallow AC post-op. So for all the traumatic glaucomas, whenever you need to treat them, it's always useful to think of the Asia Pacific Glaucoma Guidelines Matrix, which basically says diagnose the underlying cause, treat the underlying cause, identify the mechanism, treat the mechanism, and then decide what medical therapy you want to do. So the important part for us over here are the third and fourth. Identify the mechanism, treat it if you can. And I'm just going to walk you through a few examples to see what it is. So this is the situation. Why is the pressure high here? So you're basically seeing an eye with a dispersed hyphema. Also, there's some amount of layering. This is early. And the reason based on our spreadsheet is basically trabecular meshwork obstruction. And once that hyphema clears up, you hope that it will settle down. You also know that there is likely to be an angle recession as the side because most eyes with a hyphema will have an angle recession. So the long-term risk of glaucoma is there. So this is basically management of hyphema is what you will need over here. Now this is again a hyphema, but this is an 8-ball hyphema. And here the etiology is a closed angle. And the closed angle is because I told you that this is a dumbbell-shaped clot, which is pushing the iris from behind and also causing a secondary closure. And this is something which needs to be evacuated because you're not going to be able to relieve the angle closure otherwise. So this is, again, you're seeing a small hyphema, not much. You're seeing some amount of haze, and this haze is because of the dispersed heme and pigment and inflammation in the angle. So here, in addition to the trabecular meshwork obstruction, you have direct trabecular meshwork inflammation. And this is where the steroid and the cycloplegic is going to be very, very important for you in addition to your anti-glaucoma measures. And this, I showed you this picture before, but what I didn't show you is that this is, again, lens subluxation causing a secondary glaucoma because the lens has moved forward and half the angle is closed. And here's a closed angle mechanism in early disease. And you may need to think in terms of cataract extraction with or without glaucoma surgery, depending on how difficult the intraocular pressures are to control. And this is somebody, again, you're seeing that the AC is shallow, the cornea is hazy, you're not seeing much blood or anything there. But when you do the UBM, you can actually see a choroidal effusion. So this is somebody who post-trauma has a ciliary body swelling, and that has caused the lens iris diaphragm to rotate anteriorly. And for the ciliary body swelling, you basically need to control inflammation and you need to give cycloplegics. So once you've identified the mechanism, you can decide what treatment pattern to follow. Don't forget, sometimes or very often glaucoma is combined with other abnormalities. And this was a patient who came to us with a subretinal hemorrhage, some disc changes, ILM folds at the macula, IOPs were in this range. In the first few months, he was okay. Then it went up to in the 30s. He landed up with a visual field defect. But what was, we needed to go in and repair him. But what was the concern was that this is what his iris looked like. He had, I mean, a large dialysis and he had uncontrolled pressures. Anyway, he went in and did a trabeculectomy with an iridodialysis repair, and he finally recovered, I think, 6/9 vision and IOPs were under control. So keep in mind that glaucoma is not in trauma, can give you surprises. The best way of dealing with it is figure out the mechanism and apply specific treatment. I'd like to acknowledge Dr. Pooja and Dr. Shriyapriya. I've borrowed some of their slides too. Thank you.
Thank you, Dr. Ronnie, for comprehensively covering the whole topic on traumatic glaucoma. The PGs asked me some questions. I've shared my mobile number. So before we begin the discussion, I would address that particular part so that we can, and later on we can have the further discussion. Sir, you said in chemical injuries, there is a shrinkage of sclera. So how do we do surgery?
That's why I said, so chemicals injury, a trabeculectomy is sometimes difficult because of the damage. If the damage has been inferior, you may still get away with a surgery superiorly. Otherwise, a lot of the time we are left with having to put a tube in these eyes or doing cyclodestructive procedures.
So for postgraduates, if some amount of sclera is spared where you can create a fistula by doing a trabeculectomy, that is what Dr. Ronnie is referring to. And if you do not have any sclera left over, then the glaucoma shunt surgeries is what he has suggested. Sir, one more question. In the last examples which you have shown, you said you have shown angle open and closed, but you only said that you cannot do conioscopy in such cases in trauma.
Yes, so that's a good question. So basically, I was talking to you about mechanisms. So if you look at total if you look at a subluxated lens or a dislocated lens, the angle is very easily appreciable. The main contraindication to gonioscopy in early acute trauma is the presence of a little bit of blood in the eye with a deep anterior chamber. That is definitely a situation where you avoid doing it because you're very likely to dislodge a clot. If the AC is shallow, go ahead and do gonioscopy. You're unlikely to cause a bleed.
Why is khaki colored blood? Anyone can answer. All of us can answer meanwhile, I think. I'm asking on behalf of postgraduates all these questions.
Yes.
Yeah, please. Those are the questions they have asked us. So anyone in the panel can also answer. Dr. Bhushan sir, Prashant Bhushan sir.
The khaki colored cells are basically because of the hemoglobin has gone away, and it is actually the skeleton of the cells which is there they can be found in the Schlem's canal or even in pieces of the trabecular meshwork. And we get to know that it is an older form, or even in anterior chamber also when it is resolving. One case which showed there can be khaki colored cells. It is basically an old blood which has a resolving hemoglobin. I think so.
Okay. One more question is, How do you measure IOP when you have alkali and acid burn, sir?
So we typically try and use a toner pen there because you might get a small part of the cornea where you can do it. You can also use an eye care if you want. If you have reasonable surface, reasonable Myers, you can even do application, provided the epithelium is intact.
Can you elaborate for them for the sake of means?
Yeah, so generally, if your epithelium is intact, you can actually do appellation tonometry, provided you get reasonable Myers. If the surface is very bad, because sometimes you'll land up with, the epithelium completely off, a lot of limbal ischemia, you can use a toner pen or you can use an eye care tonometer, both of which require a very small area of contact. It's important that with a large epithelial defect, that whatever you're doing, you do with sterile precautions. Change the toner pen sleeve, use a new probe for the eye care. And if the surface is so bad or if that you can't do anything, at least do a finger tension, because sometimes that's all that's possible in the really, really bad surfaces.
Okay. Anyone would like to add further? Panelist? Okay.
Most
Sir,
of the times we are not able to do the IOP. Most of the times we are not able to do the IOP. We have to assume it only by digital means up to the time it comes down. I will ask something else later. Please go on.
So I think we can explain to them what are the clinical signs which tell you that the IOP is high in the cases where you cannot measure the IOP. One of the panelists can highlight them so that I think for that the postgraduate would be getting a hint why the IOP is high or which cases have an IOP. I think the new generation, they might not be good at digital tonometry to that extent.
May I answer?
Yeah, please, sir.
Basically, we see a very fine ciliary congestion that tells us that the IOP may be high. Then the surface of the cornea, it loses its sheen and there is a sense of dryness. And on slit lamp, we find that anteriorly it is slightly thickened as if it's pushing out, and that sheen is missing and nothing behind can be seen. Even though the hyphema is less, the contents of the anterior chamber are not that clearly visible. And the vessels are tortuous. The vessels in the perilimbal area, they are slightly tortuous. We get to know that there is some high intraocular pressure is there.
Okay. Last question which I have from them. Sir, angle recession glaucoma, you said you don't need to do immediately. So when should we do? Gonioscopy.
4 to 6 weeks post-trauma is what I had written in the slide. But yeah, sorry, Dr. Narak.
No issues. So I think I have exhausted with the questions which they had asked the postgraduate. So I think we have all the other panelists can now add or complement to whatever discussions which would be helpful to the understanding of postgraduates. Dr. Samir?
Yeah. Dr. Ronnie, actually, he covered everything very nicely. I would like to say that, as he rightly said, slit lamp examination and gonioscopy, they are the key to knowing whether the patient will develop glaucoma. And you should, when you do gonioscopy, you should also always look for angle recession, because if there is angle recession, you know that the impact of the trauma was very high, because there is tearing of the ciliary fibers from the longitudinal fibers of the ciliary muscle, which leads to the on gonioscopy, which is seen as a widened ciliary band. So angle recession must be seen. Actually, a couple of months back, I got a 30-year-old patient with a unilateral cataract, and he did not give any history of trauma. And when I did a gonioscopy, there was angle recession. So I knew that there was some trauma to the patient. And when I went deep into the history, he gave history of a ball injury. And when I dilated the pupil, actually there was subluxation of the lens also. So gonioscopy is a must. And you also have to look for cyclodialysis, where the ciliary body detaches from the scleral spur. But in that case, obviously the intraocular pressure will be very low.
I think postgraduates, Dr. Samir wants to say an high index of suspicion in a unilateral cataracts in a young. You should always look at it suspiciously. That's what Dr. Samir is driving at. Anything more, Dr. Samir, to add?
Rest, I think, as he said, you have to look for blood particles in the trabecular meshwork. any iris particles, and you have to you have to screen the patient for sickle cell disease, because in these cases you cannot give carbonic anhydrase inhibitors, and you have to keep the patient hydrated. So even if you want to give mannitol, it should be given very carefully. So that is important.
Meanwhile, I have a question. Why is there secondary blood bleeding in Hyphema cases, sir?
So basically, if you look at the way a clot behaves, clots typically retract. And when they retract, they can retract from the site of the original bleed. And that leads to a secondary bleed. If by that time the site of the original bleed has sealed, you won't get a secondary bleed. It's essentially clot retraction, which happens because of the coagulation cascade that causes the secondary bleed.
Great. Dr. Vinita, your comments and some additions.
Dr. Ronnie has covered it very well. It's very exhaustive topic, but then a few points we should also consider is a steroid responder. Like many of the patients, they come using the steroid for the long time, and Hyphema has resolved. There's no subluxation, there's no vitreous, no angle recession. Still, there is a raised intraocular pressure. So steroid can be a culprit. So one has to stop the steroid probably in such patients. Many of the patients, they forget about the trauma. And I'm working with multi-speciality. So they admitted with the head injury, they admitted with the fractures, and then don't realize that they have a glaucoma because of the systemic injuries also. So we have to be asking them a leading questions if there is a findings which are suggestive of trauma, especially if you have a sphincter tear, if you have a iridodialysis, something like that. Such patients, they also develop particle glaucoma. So the difference between two is like in phacolytic, it is basically the capsule which leaks and the protein clogs the trabecular meshwork. While in cases of lens particle, basically it is the lens material itself goes and clogs. So the pathophysiology is different, though the treatment remains the same, the removal of the lens. And many of the times, you tend to miss the subluxation or the vitreous into the anterior chamber. So you have to be carefully looking into the subluxation part, because these patients, they develop cataract early. Their progression for the cataract is faster. So raised intraocular pressure is one which is common. It is not the glaucoma, it is the increased intraocular pressure which you have to deal with. Later on, if it is persist for longer period of time, you will have a disc field changes. Otherwise, most of them, they have a high pressure. And with the pathology, Dr. Roni has explained so well, then whether it is an inflammation, whether it is an hyphema, or whatever the cause is, if you treat the cause, probably the IOP settles down without any residual damage. So basically, it is not a traumatic glaucoma to begin with. It is the raised pressure in the beginning. And once you treat the raised pressure, later on, probably, yes, that angle recession or fibrovascular membranes, the epithelial downgrowth, which gives rise to a late changes and a missed glaucoma. Basically, it is an asymptomatic disease and the patient has very minimal injury. So they are not aware of that they are suffering from the glaucoma. And all of a sudden, we just notice that this kind of a patient has a uniocular glaucoma. We put a gonioscope and realize that it is an angle recession. So it's an entity which is managed initially, but then missed later on. So as Dr. Ronnie said, that it is a lifelong threat for the glaucoma. So they should come for a regular follow-up.
Yeah, Dr. Bhushan, sir, Prashant Bhushan, sir.
Sir, I would like to add one more thing. Many times when we are washing the hyphema, a very thick one, and try to find a plane between the iris and the hyphema, we realize that there is a tear in the anterior capsule as well, and there is a cataract. After it comes out, after the hyphema has been brought out, which comes in small strings. So that is the time, if we leave behind the cataract and don't go it's very easy to watch the traumatic cataract because of its fibrous nature. That has also to be done. Otherwise, even after draining the hyphema, many times the pressure remains raised. So cataract, if it is there and if that tear in the capsule is there, I think it should be then and there cleaned along with the hyphema. I think what the panelists say, I would. Second thing is whether PG analog should be added and at which stage it should be added. I generally think they will add to the inflammation, so I don't use it. But later on, for late stages, I do use it. Whatever sir says, Dr. Ronnie sir, I will agree to it, and I would like his advice on this.
So I also agree with you that in the acute phase, we try to avoid a prostaglandin completely because it can add to the inflammation and in fact maybe even cause retinal inflammation like CME or whatever. But if it's, 2-3 weeks down the line, you're debating between surgery and a prostaglandin, at that time I would try a prostaglandin because I'm basically trying to ride out the first maybe 6 to 8 weeks. Most of these eyes settle down in 6 to 8 weeks. And sometimes it's just a few additional weeks of pressure control. And after that, when you start stopping the drugs, stop with the prostaglandin first. So that is only as a last resort before surgery, I might consider a prostaglandin, but not early on.
Thank you.
One more thing, most of the time, like I'm working in multi-speciality, so they ask me that should I stop anticoagulants? Like that's another problem, that whether you have to stop anticoagulants and that ecosprin, that antiplatelet drugs or not.
So I think before a Hyphema wash, you need to. But see, if it is for 8-ball Hyphema pressures of 50, you can't wait 5 to 7 days to do it. So one of the ways is to just go in and wash and then stop it after that, because you're worried about the rebleed. And typically, that's something I didn't mention, but if your patient is on anti-clotting drugs and has a Hyphema, we should stop for 5 to 7 days.
But Robbie, basically, sorry. The literature is
After
now quite
surgery,
evident that, sorry. Go ahead, Dr. Bhushan.
Please continue.
Regarding the stopping of anticoagulants for this particular thing, except if they are like dicomarins and all those types which can affect an INR, rest of the things we do not even stop for our PDR surgeries. So do we really need to stop? Basically, for example, if we wash the antechamber of a Hyphema and leave an air bubble or a viscofield, the rebleeds are almost not seen. So it's the
challenge here is that when the rebleeds happen, they're very difficult to manage. And sometimes, we have a series of patients actually with minor bleeding disorders who bled. Sometimes we had to go in 3 times. And we didn't even pick them up on a standard screen. Only when we picked them up on a full screen, we picked up that they had an issue. So typically, because of that clot retraction issue, we tend to avoid it.
Even most of the patients, they have big subconjunctival hemorrhage or ecchymosis around the lid. They all come that we should stop the blood thinners, that the blood is leaking. So is there any rationale to stop? I always tell them that whatever has happened, it's happened. Don't stop.
So as ophthalmologists, we are very happy to see a subconjunctival hemorrhage because we know there's nothing to do.
But it looks so dangerous, like they become scared and they want to stop all these medicines, the anticoagulants and even that antiplatelet.
But I think we should warn them, because we should explore them. Explore means, we should be aware that there can be an occult rupture behind a large subconjunctival hemorrhage, which postgraduates you should be aware. So if you see a large subconjunctival hemorrhage, almost clot-like thing in the scleral area, leave aside this glaucoma part. When you are evaluating a part of a glaucoma, look for an occult rupture, clinical, other evident signs, or you can do a CT scan where you can get a flat tire sign, sort of an indication if you are not. And if you are not still sure, it is always prudent to explore the conjunctiva rather than leave that eye like that and later on have more severe fibrous ingrowth. Yeah, Dr. Bhushan was saying something sometime back.
I was asking, sir, many times after trauma, if we do a filtering surgery, post-surgery, the it is likely to fail, and again the intraocular pressure rises. So do you propose us to use mitomycin C or something so that what is your experience on that?
Yes. So
Once in a while, I've also felt this, that after doing the surgery, the pressure goes absolutely down and the eye becomes very soft. So what may be the reasons for these two conditions and how do we manage them?
So Dr. Prashant, for the first condition, I mean, I typically use antimetabolites for almost all my glaucoma surgeries, and definitely for traumatic glaucoma, because you're usually doing it here because there is so much inflammation, debris, the eye is a hot eye. You definitely need to use an antimetabolite because it's very likely to scar. So I use an antimetabolite, I put down multiple releasables. I start with a higher dose of steroids and I keep them on very close follow-up, supplementing with 5-FU if required. Because these are eyes which we know are at probably the highest risk of failure. We typically don't like to do a trab in a hot eye, and these are eyes where we don't have an option. The opposite, where you said that, the hypotony. So that can happen because of two reasons. One is definitely ciliary body shock, because these are eyes which have had trauma and have been on multiple glaucoma medications. So one reason is the trauma. The second is because of all the glaucoma medications they have been on, the washout period of 1 to 2 weeks also hits aqueous production. And the trap is done at the same time. And the third reason is, if you look at the natural course of some of the acute glaucomas, they start settling down in few weeks. If we have been forced to go and do surgery around that time, when the pressures are also coming down naturally, you can land up with very low pressures, which is why when we're doing the trap, we tend to close them down tight, because we don't know whether they're going to go the high pressure way or the low pressure way. And we release selectively.
Dr. Prashant Bhawankule, I would like to ask you, like we didn't talk about choroidal hemorrhage. You know, in choroidal, if the choroidal hemorrhage occurs, the tension increases very much. And actually, choroidal hemorrhage, it pushes the lens iris diaphragm and you get a closed angle glaucoma and the tensions are very high. So as a retinal surgeon, what would you like to do to decrease the intraocular pressure in this? Like,
basically, choroidal tap, that is what we do about behind the muscle ring. You can, if it is causing a very severe push from behind, and if the glaucoma surgeon like you tell us that it is responsible
yes.
for it, because in that event we can do a scleral small pocket we create with a myringatome knife over there, and then we just drain it a part of it. But you need to understand that the many times, if it has presented in the early phase, it is a fluid, the blood is fluid like it drains out. But over a period of time, we need to understand it might be a clot. So the lysis of the clot happens 2 to 3 weeks later. So it would be prudent in event if the patient does not present to you in acute phase, within 24, 48 hours or 72 hours, you feel that it is there, you drain it, probably you might be able to drain it. But if it is not that, then 7 to 10 days later is the time when the blood starts lysing, and that is the time when we would like to do that tap. Another one thing, I think, Ronnie, I had one of the case, young guy, I had repaired about a year back, small cornea scleral tear. And then he, over a period of 2 years, he developed a fibrovascular ingrowth, like a cellophane-like membrane growing over the iris and the angle and the back surface of the cornea. So I think that is another mechanisms which postgraduates, and it's very resistant.
Yeah, very resistant. So it was there in one of the mechanisms, and those are the nightmares to deal with, because whatever you do,
They regrow. I peeled off that membrane angle growth twice or thrice. It was growing all across the iris surface into the, but now we have decided to do shunt for a.
Lastly, sir, I would like to ask, what is your take on the shunts? Have you ever used shunts or cetons? Because we have very poor patients; they cannot they cannot afford the work. So how can we go for that in very resistant cases, young patients?
yeah. So typically, if the conjunctiva is okay, I prefer to do a trabeculectomy, because that works. But sometimes you have a situation where there's a badly subluxated lens, there is a lot of vitreous, everything floating around. The retina surgeons are not keen on doing a sclerally fixated lens at that point, because they suspect, they're not happy with the status of the retina also. So in that case, in an aphakic eye, I prefer not to do a trabeculectomy because you land up with hypotony and all other issues. There I do an implant, but I typically do an Ahmed valve because I don't land up with gross hypotony with an Ahmed valve. But this situation is not very common. It's only in the situation where we have to go in along with the retina surgeon and they're going to leave the patient aphakic. Then we tend to put in a Ahmed valve. A valved implant is better in that situation because you get immediate IOP control. Others, you have to ligate it and wait for the ligature to absorb after 3 to 5 weeks. And in that time, you have to manage the glaucoma anyway.
Another thing in such patients, they have retinal tears. Sometimes they have a macular hole. So not only we have to concentrate on a lens or the glaucoma, but we have to look into the retina part also, as Dr. Prashant is here.
Very true. All injuries, one should not be just satisfied with whatever is obvious to you, to your eyes when you look at the eye first. Always look for the comorbidities, be it in the anterior segment or in the posterior segment. That is important. So, and a good indirect ophthalmoscopy, the moment the media permits you with a depression, is mandatory. That anything more? Yeah.
How do you consider iridotomy? When should we go for, in what conditions should we go for iridotomy in reducing the intraocular pressures in such patients, post-traumatic?
So only if there are posterior synechiae causing iris Bombay, I would consider that. Or if I have a lens which is causing a pupillary block and it's not easy for us to go in immediately and take it out. With a lens, a full-size lens, doing a PI may not be very helpful, except unless it is subluxated littleward, downward or upwards, in which case going beyond the lens might help. Otherwise, a full-size lens, if you're going to do the PI exactly where the lens is, it's not going to relieve the block. But if it's posterior synechiae which is causing an iris Bombay, then yes, it will help.
So do you think it's difficult to focus the beam on the iris in very shallow? The peripheries are shallow, though there is an iris Bombay.
Yeah.
So what energy do you use and how does it affect the cornea?
So it is difficult to do with an iris Bombay. So what I typically tend to do is let's say, suppose I'm using 3 millijoules, I come down to 2 and I do it on the slope of the iris. I do it on the slope of the iris in an area which is covered by the lid. So once you give 1 or 2 shots there, you can get through. And then the rest of the iris falls back. And then you go more peripheral and do a larger iridotomy. So with the iris Bombay, that's what I typically tend to do. Because I agree with you, it's very easy to damage the endothelium.
If it is a penetrating trauma, there is usually a hypotony to begin with. And if you have a corneal tear and a lens which is also ruptured, partially, not fully, do you recommend combined or staged surgery?
That's a nice controversial question. So everybody has different ways of doing it. I prefer to close and just clean out whatever obvious lens matter is there. And do the lens once the eye is a little quieter, maybe even just a few days or few weeks later, but do it when the eye is a little quieter. But I know some of my colleagues prefer to take out everything at the same time. So typically, when you go in an acute situation, you don't know what surprises may be there.
Yeah, definitely inflammation, vitreous loss means you have many things to deal with.
And you have a very sticky iris, very sticky tissues post-op, and you might develop synechiate from the iris to the capsular remnants, making a secondary lens also difficult later.
I think basically you have to remove whatever is there with the tear, whatever is there you can see in the anterior chamber. Like if you see either lens particles, whatever, hyphema, that you have to remove. Whatever you can see, that you have to remove. Blindly, you cannot do anything like.
Yeah, I think
for children, sorry.
Sorry.
I think for children, I think it becomes really difficult if you are taking into the GA, then 2 times GA. But then if you do together, there is a lot of inflammation. So both ways, it is tricky.
Yeah.
Then lens IOL power also becomes difficult, like in children, in penetrating injury, like how.
Because they come with that trauma, that age group of less. So you have to take them to GA.
Yeah, that's the
Tricky
risk factor.
cases.
That's a tricky thing.
What we follow protocol at our place is a clean cut wound, minimal cataract, means minimal damage to the capsule, no vitreous in the anterior chamber, means no involvement of posterior segment on an UB, means on a B scan. This is the cases where you can think about a simultaneous wound repair with a cataract extraction and putting a lens. Whenever there is an involvement of iris tissue, damage to iris tissue, posterior capsular rupture, vitreous, you should never do. You should do a primary repair with cataracts removal if the cortex is floating into antechamber. Let the capsule fibrose and then take 4 to 6 weeks later, you have a better capsular support to play with and have a better quality of IOL. That's what we do at our place. So I think we had a wonderful discussion today. Any more additions for the sake of postgraduates beyond our own discussion? Yes, sir. Bhushan, sir, Samir, Dr. Samir, Dr. Vinita, anything more to add? Okay. So fine, guys, we had a wonderful discussion. We had all the stalwarts from glaucoma helping you in understanding the various mechanisms, the ways to treat a traumatic glaucoma. And we have answered the queries, the queries which you have answered. So hope this today's topic must have been very easy. And next time, if you ever have these questions, you would be able to get at least 80 to 90% of the marks, whatever that marks for that question is allotted. So thank you, one and all. Thank you, all the panelists.
I would like to say thanks to him. It's very nicely covered.
Thanks a lot, Dr. Prashant sir. Thanks a lot for taking it.
Oh, my sincere most thanks to Dr. Ronnie George, who is the director at Shankar Netralaya, as well as head of the department there, for sparing time for all my postgraduates, as well as Dr. Samir, Dr. Vinita, and Dr. Prashant Bhushan for enlightening our next generation.
It was our pleasure. It was our pleasure.
Thank you.
Sir, it was our pleasure, and thank you for making us the part of this webinar. Thank you, sir.
Thank you, sir.
Thank
Thank
you,
you so
Dr.
much.
Prashant. Thank you for the invitation.
Thank you.
Thank you.
Sir,
Bye.